Welcome, everyone. We're going to be getting started in just a moment. And thank you for those of you introducing yourself in the chat. We can continue to introduce ourselves while we're waiting for everyone to join. Good morning, everyone. Welcome to our webinar today. I'm going to do a little bit of housekeeping. My name is Lacey Hensley. I'm the director of the Institute for Coordinated Community Response, and we're so glad that you've joined us today. So as we get started, we want to encourage you to use the Q&A box at the bottom of your screen to ask questions throughout today's presentation. I'll be monitoring that for our speaker, and we'll definitely make sure that we get those questions answered. And if you'd like to make comments or interact with the speaker or any fellow attendees, as you're already doing, please use the chat box and make sure that everyone that you've selected everyone to see those messages. If you have any technical difficulties, you'll select the all panelist option and an ICCR staff member will assist you. So before we begin, a little bit about the Institute for Coordinated Community Response. We began our program of the Conference on Crimes Against Women. It was created in 2018 as a training and technical assistance program whose mission is to work alongside rural communities to improve their collaborative systemic responses to domestic violence. ICCR works to accomplish this mission in two ways: by saturating the state of Texas with effective criminal justice responses to domestic violence, and by ensuring every community across the United States, no matter how small, receives the training they need to provide justice for victims and hold offenders accountable. In addition, ICCR's virtual trainings like today's webinar allow us to reach communities anywhere in the country. In all of our trainings, we work to center the unique needs and strengths of rural communities while providing practical skills and tools that can be immediately implemented. So although our trainings are geared towards rural needs, our trainings are relevant to any practitioner who's committed to eradicating domestic violence. So thank you for being here today and for your dedication to improving your own community's domestic violence response. You can learn more about ICCR at our website, www.instituteccr.org. And I encourage you to sign up for our e-blast, and so that you can stay abreast of all the current trainings that we have going on and our free on-demand learning that we have, including our roll call trainings. So now I'm going to introduce today's speaker. Marian Contreras is a registered nurse. She's the Violence and Injury Prevention Manager at JPS Hospital, a busy level 1 trauma center in Fort Worth, Texas. She's practiced nursing over 4 decades. Marianne focuses on trauma, behavior, environment, and policy to develop, implement, and evaluate injury prevention initiatives. Using national, local, and trauma registry data, she coordinates and collaborates with community organizations to develop trauma education and injury prevention strategies. She is active in the state's trauma system, national nursing and injury prevention organizations, and sits on several community boards. And I love her and adore her, and she's one of my friends that I have the pleasure of knowing. So thank you for being here, Mary Ann. And if you want to take it away, I will stop sharing.
Awesome. Thank you, Lacey. This will stop. Yes. So I appreciate that. And my favorite part of that was I love you and I love you back. And so I enjoy working with Lacey. I've worked with her for a long time in different capacities. And she is a true friend and such an advocate for a lot of people and a lot of the community that I serve and my hospital serves. So we're here today to talk a little bit about healthcare implications for intimate partner violence and human trafficking. Of course, it can really go to any large organization. I do want to say that there is some potentially disturbing content. I like to let people know that, a little trigger warning. What I have learned from the work that we've been doing over the last 4 or 5 years is that almost every single time that we give a talk on this, someone comes up and tells me their story, which is, I always appreciate when somebody shares their lived experience, but I just want you to know that, hang on, I'm just trying to make my screen a little, there we go. I always appreciate when someone has their lived experience, but I'd never want to cause someone to be triggered by my content. So there you go. And it's not letting me, hang on, move forward. There we go. Okay. So this is one of my brand new little puppies, and I like to put happy pictures on because it's a heavy topic. And so our objectives are to identify similar victimology in both intimate partner and human trafficking. You'll be able to be familiar with some health outcomes that are predisposed in folks that are experiencing intimate partner violence as well as human trafficking. We're going to highlight a couple of different populations that are at risk for human trafficking. And my favorite part of the whole thing actually is some of this information about neurochemicals, neuroscience that influence trauma and behavior and influence why people make decisions that they do. All right, here we go. There we go. So I don't have any disclosures. That's my second puppy. That one's Maisie, and that one's Maya. They're a little bit bigger now, not too much, but a little bit. I don't have anything to disclose. So a little bit about where I work. I work in a level 1 trauma center in Fort Worth, Texas. Right now, we are the only level 1 trauma center in Tarrant County. We will have a little bit of competition soon, but there's enough to go around for sure. We are a comprehensive stroke center. We have the county's only psychiatric emergency center. And we have a lot of clinics, and we have a lot of people that come to our emergency department. You can see 121,000 average emergency room visits, which comes down to about a little over 300, 350 a day in my emergency department. And my emergency department only has about 60 beds. So we turn those people around every 24 hours. So it's a busy place. We do have the nation's largest family medicine residency. So that's just a little bit about where I work. So a lot of you already know this, but I always like to start with some standardizations of definitions of intimate partner violence. And you can see that. I'm not going to read it to you. But intimate partner violence occurs with abuse and aggression. Sexual violence is very common. Stalking, which is a felony in the state of Texas, as well as 48 other states, is very, very common in intimate partner violence relationships. And there's a lot of psychological or power and control, which we're going to talk about as well. And you all probably already know all of that, so we'll skip through that. The power and control wheel is something else out of Duluth, Minnesota, that I'm sure many of you are familiar with. There's a lot of similarities between intimate partner violence and human trafficking, and we're going to talk about what those are in a few minutes, but we're going to focus right now on the intimate partner. But they both produce and manipulate vulnerable victims. Intimate partner violence is about the abuser using power and control. And when I give talks like this, I usually refer to the abuser as the male, although we do know that abuse does occur in the other way around, with the female being an abuser, or in male and male relationships as well. But you will hear me refer to the abuser often as the male and the survivor as the female. One of the things that we've noticed in a lot of the work that we've done in my hospital, and we're going to talk a lot about that, is there is a lot of isolation. Certainly all of these spokes in this power and control wheel are really important, but we see a lot of isolation, controlling who the victim or who the survivor is allowed to see, is allowed to work or not work, family members, moving them away from their familiar home, as well as using a lot of coercion and threats, especially with children. In the state of Texas, we have a very diverse population, and we also hear from some of our survivors that they are terrified to report anything because they are not legal residents in the country. And we'll talk a little bit about some pathways to citizenship. I'm not going to get into any of the political things, but that is something that is used to hold people back from any type of reporting. So in Tarrant County, where I am, you can see in red, it's 1 in 3 women have experienced intimate partner violence versus nationally 1 in 5. What we also know in Tarrant County is that about 56% of all violent crime is family related. So we have a lot of issues right now, and there's a big focus in our county, not only on violence, but family violence. The Wall Street Journal did a very extensive expose a couple of years back and did quite a bit of research that let us know that about half of all female homicide victims in our country are killed by a current or a former male intimate partner. So that's huge. This is a public health problem, which is one reason why our organization and my trauma center is looking at ways to mitigate and reduce this. Some of the newer research, you can see some of my references there at the bottom. Some of the newer research is also showing some of the negative health consequences of intimate partner violence. Oftentimes, as either advocates, practitioners, or even a friend of someone, we often limit the consequences of intimate partner violence to just, and I use that word very lightly, just to say it is just the physical or injury findings. But as what we have learned through the Adverse Childhood Experiences study, we also know that exposure to violence and abuse behavior has a tremendous impact systemically on the entire overall health of someone who is experiencing that, not only physically, but of course, psychological. We know that because of the higher levels of the stress hormones, that it impacts the way the heart functions, the digestive system, the reproductive system, the neurological, the muscles and the bones. A lot of that has to do with some of our stress hormones, including cortisol, which creates a giant inflammatory response, which are systems that are in our body. Each of those systems they don't like a giant inflammatory response. It causes damage to those health systems. We also know that some of the other health consequences are the brain health impact, such as depression, PTSD, other types of behavior issues. And so one of the newer findings in some of the latest research is that we're seeing women and people that have been impacted by the physical side of intimate partner violence with chronic traumatic encephalopathy. Some of you may be familiar with that term if you're a football fan, like I am, and you watch football. And we've learned over the last couple of years some of the detriments from tackling, from being struck in the head, even with a helmet on. So as you can imagine, many victims obviously don't have a helmet on, and some of the physical impacts and the blows to the upper body and to the head, we're seeing physical signs of chronic traumatic encephalopathy on MRIs, on CTs. So they also have a higher risk of higher health risk behaviors. So people, as a nurse, we use the word self-medicate a lot. So people deal with stress, or in their coping mechanisms are very varied or very different. And so some people will smoke, some people will use excessive alcohol or other types of substance. And also there's the sexual risk behavior that is a part of that as well. So you can't talk about intimate partner violence without talking about strangulation and having to do with power and control. Near fatal strangulation is present in over half of all intimate partner violence relationships. I said near fatal. Half of all strangulations, including fatal strangulations, leave no external marks. Hence that photo there that you see of those two beautiful women with the necks that have nothing on them. Those women could have been strangled anytime, and you may not ever see it. So it only shows up about half the time in both people that survive as well as people that we see in our medical examiner's office. You can see in that anatomy and physiology picture that the carotid artery, which is the red one here, and the jugular vein, which is blue, are super close to the surface. And there's really not a lot of protection around them. There's some ligaments and some tendons that are not depicted here. You can see a little slice of it right there, but there's not a lot of protection. They're very close to the surface. Also, the larynx, or the windpipe, in the middle, your airway, is very close to the surface. These areas that are super close to the surface are easy to compress. An example, it takes about 4.5 pounds per square inch to occlude or close off that jugular vein. And the jugular vein. And the jugular vein is the vessel that carries the deoxygenated blood from the brain back down into the pulmonary system to get reoxygenated. So about 4.5 pounds per square inch. It takes about 5 pounds per square inch to occlude or close off the carotid artery. Now, the carotid artery comes straight off of the aorta, and it's all fresh with good nutrients and oxygen that keep the brain cells, the brain tissue alive. So, and the larynx, because if you feel your throat, you can feel it's a little firmer because of that cartilage. The larynx takes about 33 pounds per square inch. So these are little bits of important information. And let me give you something to compare that with. An average handgun trigger is about 6 pounds per square inch. And an average man's handshake is 120 pounds per square inch. So you can see how very vulnerable that system is. Those vessels are the underlying structures in the neck. You can see how very vulnerable that they are. Now, there are times when there are marks. And this particular victim, this particular survivor, actually has what we call petechial bruising. So petechial bruising happens when there's pressure on that neck, that pressure from the outside, either with hands, piece of furniture, a knee, an arm, a ligature device like a cord, a rope, a piece of jewelry, that causes those vessels to compress. So nothing can, the blood vessels and the oxygen cannot get up to the brain because you're creating a dam effect, and nothing can come down from the brain, anything above where that pressure is on the neck. And when that pressure occurs and it is sustained anywhere from 10 seconds to a couple of minutes, those vessels become so engorged or so full of the blood that can't go anywhere that the little small vessels, they burst. And when they burst, that's what it looks like, little petechiae, little burst vessels. Now you can see that here on her neck. You can see it on her face. Part of the picture that I have cut out, she has petechiae actually on her eyeballs, behind her ears, inside the lip of her mouth, on the roof of her mouth, because again, it's above where that pressure is. And what that does is when those burst, they're also bursting in the brain that we cannot see. And when you have the bursting of the spilling out of the contents of those vessels on the brain tissue, that's very damaging. So that is an external sign. You can also see on this particular survivor, this mark here. And so that most likely was when she was trying to remove the hands, because I know this person, she was trying to remove the hands from her neck, and she probably scratched her neck. So that's a common thing. I saw we had some law enforcement people in on this webinar. And so these are things that you all probably see and recognize for sure. We know through research that strangulation is a very strong predictor of lethality. In the Journal of Emergency Medicine, there is several founding articles from 2001, 2008, and then many, many more in other peer-reviewed journals that let us know that strangulation is a predictor of lethality, to the point of where the research tells us that that victim right there is 800 times more likely to become a victim of homicide if they have experienced non-fatal strangulation down the road. In our county, we're really fortunate that our district attorney's office even has a specialized felony prosecution team for strangulation, because it is a felony in the state of Texas, as well as 40 other states, as I mentioned. You can see here some of the common symptoms. So here's the thing. When I mentioned that strangulation is a bit of power and control in the previous slide, the strangulation piece causes that victim to become very, very compliant, because that victim comes very near to death when they cannot breathe and there is no blood supply. And it is a terrifying feeling. And so these minor symptoms, these first couple, 2 or 3 that are minor, ringing in the ears, a sore throat's the most common complaint of someone who has been strangled. They have a loss of consciousness. LOC is loss of consciousness. Those 3 things are fairly not huge, but they are so thankful to be alive that they often underreport, don't talk about it. When it comes to loss of control of bowel or bladder, that usually occurs anywhere from a minute if it's a very tight occlusion, a very tight pressure on that neck, loss of bowel and bladder control. That's because the actual brain stem, the primitive part of your brain that tells you, that makes your body breathe without you having to think about it, is about to die. So when someone talks about strangulation and their experiences, they often are underreported. They often use the word, I just got choked out, I'm okay now. But the abuser knows that the victim knows that the abuser has the power to take that person out, to take the survivor out, completely kill them, or has the power to let them live. And that's why they become very compliant as they are in that relationship. So let's talk a little bit about what often occurs, some co-injuries that occur with strangulation, what I've seen. So I work with the DA's office, and so I read a lot of cases that talk about some of the victimology, some of the injuries, some of the ways that person has been abused physically as well as psychologically in that relationship. So often along with the strangulation comes very similar to like head banging, what we see in small children that are abused by parents, the head banging on the floor, the head banging on the wall. And when I mentioned earlier about chronic traumatic encephalopathy, this little abbreviation right here, this is a very common occurrence in people in abusive relationships. And what happens is it causes this, what we call a persistent post-concussive syndrome. So these people who are in this situation will come to my emergency department and they're all over the place. They are saying, well, 2 weeks ago this happened, but yesterday he forgot to do this. And like last week this happened and I don't remember, I knew I got choked out, but it was only for a couple of minutes. I remember being in the kitchen and I woke up in the bedroom. They have lost consciousness more than likely if they have memory from one spot and then waking up in another spot. But they have this post-concussive syndrome, which they may forget words. Their stories are not linear. They're all over the place. That is a part of the damage that has occurred as a result of strangulation from the lack of oxygen and blood flow, as well as the traumatic brain injury from the pounding on the wall or the floor, or even a facial assault. But they have very poor recall, and they often will just not share as much information. We see that with our patients. They don't want to share because they feel like something's wrong with me. So now we're going to jump a little bit and go to human trafficking. And so this is legal verbiage of what trafficking is. And we know that there's 2 kinds of trafficking. We focus so much on sex trafficking, which is quite prevalent. And we always think of the Liam Neeson movie Taken, and that's usually not what happens. And I know law enforcement can back me up on that one. But there's sex trafficking and there's labor. And in the state of Texas, we have a lot more labor trafficking than we do sex trafficking. But again, these are the legal definitions of that. Essentially, and you've probably heard this, human trafficking is a form of modern day slavery. Texas, my state, is second in the nation on the number of phone calls to the National Human Trafficking Hotline. We're just behind California, actually. So those really smart people in Duluth have begun to see a lot of similar victimology between intimate partner and human trafficking. It's so much to the fact that what we're learning is that one can move to the other and back and forth. So they created a power and control wheel, or they defined a power and control wheel for sex and labor trafficking. And the spokes are very, very similar, but some of the details of those spokes are a little different. What we've seen at my hospital in screening for human trafficking is that many times the victim doesn't even recognize themselves as being trafficked. Something to keep in mind. They may not want to be rescued like Liam Neeson's daughter in the movie Taken. They may not even see that. And we're going to talk a little bit about why that is in just a second. So more legal definitions of what it means or what the elements are of human trafficking. There has to be some type of recruitment and moving about. And moving about doesn't even necessarily mean moving state to state. A lot of people who don't know a lot about trafficking think, oh, it's coming from another country to the United States or the other way around. So the action taken, it can be moving from house to house or from hotel to hotel or from area to area, especially in labor trafficking. The traffickers will use force, fraud, or coercion to lure their victims. They force them into labor or to some type of commercial sex exploitation. So the humans, again, become a product that the traffickers can make money from. They isolate them, they hide them. The trauma cause can be so, as I mentioned earlier, the trauma that these folks experience as they are groomed into this role, and they are very carefully groomed, that again, that leads to a person maybe not even understanding or identifying as being trafficked. Something to keep in mind as you work with folks. So let's talk about what are some of the risks for people being trafficked. Who are people that are more likely to become trafficked? The grooming starts very, very early. And the grooming, people that are children that are in the foster or CPS care are at a tremendous risk for becoming a trafficked person. And that's because often these children are in foster or CPS care because they've had to leave an abusive family, or a family that maybe has a parent with substance use, or a family that has a parent incarcerated. So these kids really don't have a strong family structure. Poverty and homelessness, one second, also contribute to that risk for becoming trafficked. Addiction. So again, those parents that are addicted, or even the youth at home. So what we've seen is these kiddos, and as young as 9, but the average age is typically where they are recruited into trafficking, whether it's labor or sex trafficking, is between 11 and 12 years of age. So flip your mind into what you know about gangs. We know that a lot of times young people join gangs because of very similar situations at home. They don't necessarily have a strong family support system. They don't have that support system. So they're looking, as humans, we all navigate toward our tribe, our team, our family. We want to belong. We want to be a part. That is normal human nature. We want to be a part of a tribe. And so when the youth do not have that, many of them will run away from home. And as they run away from home, there are lurkers and people that recognize that. Maybe it can be a man, it can be a woman, it can be a teenager, and that someone that recognizes a sense of need to belong and a sense of no self-worth. So that's what that little diagram here is at the bottom. So oftentimes through a research project, what one particular former trafficker said was, I knew when I went up to someone in the mall, a young girl in the mall who was perhaps alone, and I said, oh, you look really nice today, and got a smile. I knew from that minute that I had that girl, I had that young person. And so they take them in and they groom them. And we'll talk more about that. Another thing that puts people at risk is their legal status. And when I say legal status, are they an illegal resident, or are they a legal resident? I mentioned that earlier, that often the abuser or the trafficker will use that as leverage to keep that person, especially in labor trafficking, to keep that person as a part of their products that they use over and over again. So this is my state, and you can see the numbers there. A few top venues for labor trafficking in the state of Texas is domestic work. Our folks that work outside and do landscaping work. Top venues for sex trafficking in the state of Texas are the spa business as well as massage parlors, right? I mentioned that we're number 2 behind the state of California. And I also mentioned that traffickers can be family members. We've had in my organization, we have been screening now for about 4.5, 5 years. The last 3 for trafficking as well. But we've been screening, and what we have seen is that people come in and they are that person's aunt, they are a grandmother, they are an uncle, and they are using their family, they are selling their family, and they're using them essentially as a form of slavery to have their income to make their way in the world. So anybody can be suspicious of that. We had a young 14, 15-year-old girl who came to our hospital to deliver a baby, which that's a red flag right there. And when we contacted, and finally she gave us the number for her mother, and I put air quotes, but for her mother, I mean, it wasn't her mother, it was her trafficker. And that was an eye opener for our folks in labor and delivery, for sure. They did a great job identifying and calling in the right resources, which we'll go over in a minute.
Marianne, I'm so sorry. Can I just say, I know you've mentioned a couple times your screening process. Are you going to go over that a little bit more as far as how you started that? Perfect. Thank you.
I am, because I kind of just wanted to give a little bit of a background, which a lot of you know a lot of this, but I want to make sure we're all kind of on the same page. And then I'm going to go over how we instituted it here in our organization and how it can be replicated in any organization. That coercive control, I like this slide, because this is the hand that's holding the puppet strings represents either an abuser or someone who is the trafficker. And that victim or that survivor, whichever term, learns how to respond to survive. These people, we look at them, we say victim, but they really are incredibly brave and strong in order to survive. And they learn the behavior that they have to do according to what the response that a particular abuser or trafficker wants. And they learn that so that they can survive. But the problem is that over a period of time, our brains begin to think that way. And we're going to talk about that next. And it causes different neural pathways, which cause long-term psychological consequences. It becomes very hard for the survivor to disassociate from their owner or from their abuser. It actually strips away their own sense of self. So here's the science. I will tell you that when we first started doing our screenings and in a much more trauma-informed way, and as well as using correct tools, the nurses want to fix things. I'm a nurse. I want to fix things. You come in with this. I want to give you a shot of penicillin. You're going to be okay. You have a broken arm. We're going to put you in a cast. You have an appendicitis. We're going to take it out. We fix things. Nurses fix things. And so the nurse's response to me was, well, why don't they just leave? And we've all heard that. But when I started reading, doing a lot of journal review and the science behind it, why don't they just leave? Why would you stay? Well, when you first enter into a relationship, whether it's dating or whether you're being groomed for trafficking, it's a beautiful thing. That person doesn't start out on that first date with a physical abuse. That person doesn't start out on a first date going, you're going to go over here and make this quota of money every so many hours so that you can survive. No, it's a grooming process, and it's over a period of time. And during that period of time, psychologically, this unhealthy attachment from these folks that are at risk develops. And when that unhealthy attachment develops, what happens neurologically in your brain is that your brain has this incredible neurochemistry. Oxytocin is one of the chemicals, one of the hormones, one of the neurochemicals that gets dumped into your brain. Well, oxytocin, excuse me, causes a bonding effect. It creates pathways in your brain that say, oh my God, this person is so good to me. I left my home where I was getting assaulted every day, or I was getting beat on, or I didn't have enough food, or I was getting abused every day. And this person is taking care of me. And this person is feeding me. I've got a roof over my head now. And so it's before the actual abuse starts. So oxytocin is also a chemical that gets dumped in a mama's brain when she first has a baby. And when that oxytocin gets dumped, there's physical signs. You have dilation of your pupils. You have all kinds of responses that cause you to go, oh my gosh, it's like my puppies. I see my puppies and my oxytocin goes crazy because I just want to bond with them. I just love them so much. So this is what happens. And then along with the oxytocin, dopamine is another chemical that gets dumped into your brain that creates a craving. So we know through research that dopamine receptors in the brain are what our dopamine gets released in the brain when people who have substance use disorder, whatever use it is, this dopamine response happens, causing this craving. And someone raised their hand. So I'm going to let Lacey take care of that. This dopamine response causes this craving, and you want to be with this person. You can't stop wanting to be with this person. This is really important information for you all to know so that you all know how to approach people. But what we've discovered in our screenings here at JPS is that this is really important for the victim to know. I had a young woman in my office who was like 4.5, 5 months pregnant. She had been with her husband for a length of time, and he was physically assaulting her to the point of beatings and stun guns. And she looked at me, and she's sitting in my office, and we're just talking. And she said, I am so stupid. I still love him. And I stopped and I said, okay, here's why you still love him. And I explained the oxytocin and the dopamine and how it creates these neural pathways in your brain that you do not have a stopcock. You don't have a spigot that you can turn off in your brain to stop that. But when you begin to realize it, you can begin to learn how to channel your brain in another direction. And she was unbelievably relieved because in her head, she had been told from her husband for a long time, all the awful things, how horrible, how dumb, how stupid. And here she is still staying with him and being pregnant and being a stun gun used against her. That brought her the courage and the ability to accept resources for community services. She's doing fantastic. So this is some of the nitty gritty, Lacey. Here's some this is what we discovered. In my hospital, we began to participate in an adult fatality review team that was a multidisciplinary team in our county that included pre-hospital like EMS. It included the medical examiner, the DA's office, law enforcement, hospitals, victim services folks. And we wanted to see why people who were in our community were falling through the cracks and not accessing community resources. In fact, that number 12% up there, when I started digging into some of our electronic health records, I discovered that in our emergency department, we were only screening about 12% of all people who came through our emergency department. And remember how busy I told you we are, 350 people every 24 hours. And those people that they were screening were people that came in because they had been assaulted. We weren't screening motor vehicle crash people. We were not screening people that came in with a headache. We were not screening people that came in with a bellyache, with whatever they came in. Most people will come in with something And then you have an opportunity to screen. We're mandated to screen for suicidal ideation, and we're supposed to be screening for some type of abuse. But we use this screening tool that is not a validated tool. So you can see this question here. Do you feel like you're treated well by your partner, your spouse, your family member? How does that tell me as a nurse? What if I am being abused at home and that's normal to me? Or what if I grew up in a home like that? And if they say, that leaves everything up to the nurse or to the screener to decide, is this person a victim of intimate partner violence? And so it was a non-validated tool. And at the end of this screening tool, we also found out that there was nothing for the nurse to fix. When I say fix, there was no resources at the end of this tool. And this is something that my entire organization, we thought we were being compliant, but we weren't. So we dug a little bit deeper and realized that in our community, we have so many resources. We have the Crime Victims Unit at the city of Fort Worth. We have the Women's Center that has counseling, that doesn't cost anything, that has all kinds of crime victims resources and funding applications and ways to help people. We have organizations that work with substance use disorder that are resources for our patients. We have One Safe Place, which is a family justice center. We have Safe Haven, which is our sheltering organization. We have Unbound, which is our human trafficking organization that works with the state and federal levels. We have so many resources that we were not aware of and did not know how to connect. So one of the first things that I can tell you that we did, that you can do, is to find out what's out there. I did not know about most of these organizations. There's the Phoenix is a support group for people with either substance use or alcohol use, and none of these organizations charge for their services. There's a lot of federal and state and local grants that support these groups. They thrive. And so we began to connect with each of these groups and develop a relationship. Yes, it took a lot of time, but that is important, because when you develop these relationships with all of these groups, you create essentially a net. You create a pathway. You create something that you both have in common. Nobody wants to have to take care of people that have been abused or that are in traffic situations. And so when you create these relationships, you define and find your common ground and what you can do to help each other. And it isn't just, okay, go to One Safe Place, go to Safe Haven, go to Genesis, go to, wherever it is. You create these warm handoffs that you're able to pick up a phone and talk with not only the people in these organizations, but you can hand the phone to the victim who can talk. Because what we've also discovered is that our victims or our survivors want to know what's going to happen when I call these people. And so being able to be honest and open and create that safe space for conversation, it causes a much greater incidence of accepting resources. So this is really, really a key piece of any successful referral program, and working together in tandem. I explain this to our nurses. We have organ donation procurement. We have organ donation procurement agencies. And when someone has been declared legally brain dead, we call them, and they actually have offices in our hospital to talk with the families. Would you like your family member to be they do it in a much different way, but to see if we can engage that family to accept, helping another family. So when you consult, and we've talked to our nurses about this, when you consult one of these other resources that you see here in front of you, it's the same kind of a thing. It's a consult. It is another community partner that can do their specific work, whether it's drug, substance use, family court with challenge, or it is counseling at the Women's Center, help with all the legalities and the psychological services that Unbound provides, as well as One Safe Place and Safe Haven. Whatever those are, each of us have a piece, and we're all responsible for our piece. And our piece, and in my institution as a healthcare organization, is to screen, identify and offer those resources. We do not have those resources in my hospital. I don't have some place to be able to send someone as in a sheltering organization. I may not have the social work support or the counseling support because my hospital is full all the time. But these organizations service these folks. So in talking about that, where's my cursor? There we go. So I mentioned that the nurses are always like, and the physicians and the techs, can't they just leave? So when we began to work with all those organizations, we brought them into our organization to give talks to our residents, our physician residents, our nurses about what they knew, short talks, 30 minutes during huddles, during staff meetings, during when they would have roundings. We brought them in to talk about not only the services they have, but the reasons why our victims act the way they do, stay the way they stay. And then we also asked our staff here at the hospital, we need to think about our own implicit bias. So our own implicit bias is an unconscious bias that leans toward, why doesn't this person just leave, or this person is a drug addict, is a crackhead. This is our own unconscious bias that we grew up in the way that we grew up in our environment and our families and our neighborhoods, that we have an opinion that we didn't necessarily consciously develop. And so you need to be able to look inside yourself and go, you know what? Yep, this person has a drug problem and they are being sold from one person to the other, but they've if they just quit using that drug. So we have to think about how we look at people and what their lived experience is and what our lived experience, especially that person's their lived experience. Also, you need to think about your own personal history regarding intimate partner, because what we discovered in some of our work when we first initiated this was that it was very triggering for our staff. And so we developed some plans. Now, when we're brought up, we know in healthcare that the social determinants of health, which are economic stability, do you got enough money to be able to live in a healthy manner? Where you live, what is your zip code? What kind of education? Do you have any education? Do you have access to food and healthy food? Is your neighborhood safe? Is where you go to school safe? Are you hanging around people that are safe? Are you hanging around people that aren't safe? And do you have access to a healthcare system? So those are all the pieces of social determinants of health. So your zip code actually has a greater impact on your life expectancy than your genetics. In fact, where my hospital is located in 76104 in the state of Texas, it is the lowest life expectancy zip code in the state of Texas. So there is a lot of violent crime in my zip code here where I work. There are not a lot of access to food. A lot of people don't have any access to education. They live in neighborhoods that are not safe because there's no lights and there's dogs and there's gangs. And so these things are very important in shaping that victim in what they are able to tolerate and what their support structure is and the choices that they eventually make. So both intimate partner and human trafficking are public health consequences. But one of the things that I like to share is in a particular case, when we first started screening, and I'm going to show you our screen in just a second, we're getting closer, I testified in a case where the dad was severely abusing the mom and they had a young son. I did my part on strangulation. That's all I talk about is the anatomy and the physiology. I don't say this person did it or didn't do it or she egged him on. I don't do any of that. I just teach anatomy and physiology. And they found the father guilty, and he was being sentenced to a very long time in prison. And in front of me, I had never met the survivor or her son, and they were sitting several rows in front of me. And I watched as they sentenced this gentleman or this man to prison. And I looked at the mom and I realized that now she's going to have to get a second, maybe a third job to support her family. I looked at the little boy who was looking at his dad, and he loves his dad. Remember the dopamine and the oxytocin, and she still loved him. And I looked there and I thought, here's a young boy that's going to now grow up without a male figure in his home. So this is public health. This is really important. And this is why we need to know about these kinds of things. And yes, he did it and we held him accountable, but the fallout from that is absolutely tremendous. So when we talk to people that are impacted by intimate partner, we use this term a lot in healthcare, and it's called trauma-informed care. So in my world, trauma initially was like the physical trauma, the car crash, the gunshot wound, the stabbing. But we know that trauma impacts our brain. We hear a lot about that right now. But what trauma-informed care is, it's a lot of things. There's textbooks written on it, but very quickly, it is transparent. It's like when I was talking to the young woman in my office. No, you're not. Yes, you're still in love with him. You can say that out loud. You don't judge it. Yes, you're still in love with him. Here could be a reason why you're still in love with him. These chemicals in your brain, it fosters a sense of trust. It fosters a sense of, I can talk to this person, whether they are a police officer or in any type of law enforcement or in the healthcare system or in the social justice system, whatever it is, they can talk to them. What we're also discovering is peer support models, especially in trafficking, is that Unbound uses peers, people that have lived experience in the human trafficked world, to be able to connect with, to create safe spaces with the victims that we see here at JPS. And when you think about our implicit bias, our unconscious bias, everybody has them. You have to be able to think about them and figure them out. We also want to consider cultural, historical, and gender issues. So step back and think about that when you talk to folks. But the biggest thing you can take away is creating this safe space of acceptance. If you go in there and you tell somebody what to do, how are you different from their person that's trafficking them or their person that's abusing them? Because they're always being told what to do. They don't have a choice. Remember the puppet picture. And we don't need to necessarily know their whole story. We need to connect them with those community resources that have the specialized training and the specialized knowledge that they can help them, whether it's trafficked or intimate partner or a combination thereof. So when it says limited exposure to re-traumatization, we don't want to do that. It's really important that we let that adult over the age of 17 make their own decisions. So when we first started screening, we focused with our nursing residents in specific targeted areas. So if you want to make organizational change, no matter what the size of your organization, I would say start in a small area. We only started in one section of our emergency department. We started in the trauma section because that's my favorite section, where people come in for all different kinds of things, not assaults, yes, but car crashes, falls, all kinds of things. So we started in specific areas with a piece of paper with our screening tool that I'm going to show you. And when we started this, we did very specific education to those screeners. Some of them were nurses, some of them were physicians, some of them were medical assistants, some of them were the unit clerks. We wanted everybody to have this knowledge. And we didn't just teach them about the screening. We did that, but we talked to them about implicit bias. We talked to them about trauma-informed care. We made sure to be successful that we had to fit that specific unit's workflow. You don't want to say, well, we know when you check a patient in, you've got to hook them up to the monitor and this. We don't want to say, don't do that. We want to say, how can this fit into your workflow? So this isn't me telling those staff members there what to do. It's like, okay, here's what we want to do. How can this fit into your workflow? What we discovered is that in our clinics, that workflow was very different than our emergency department, than in our urgent care. We want to fit the workflow because the more you fit that flow, the more compliant that staff member will be. And we created focus groups. So after they spent 2 or 3 shifts doing these screenings, they came back and talked to me, and we recorded. And what was some of the barriers? Well, one of the barriers was one of the nurses in the clinic, when they were bringing back a patient to screen, the nurse that was normally working in that clinic told our resident, you don't need to screen that person. She's a crackhead. She comes in all the time. Well, now because they had education about why people use substance, because we know they're at higher risk for substance, both in human trafficking and intimate partner. you know what? We have to take the crackhead piece off the table. And I hate using that word, but that was the exact quote. And so we made sure that we educated about people self-medicate. So they identified barriers. They also identified their own individual biases. We had nurses and staff members that had experienced intimate partner. They said, I don't know if I can do this. So instead of that, then we developed ways to switch assignments, and we had to gain that staff buy-in and to make it compelling to understand why our patients are in the lived experience that they are in. You have to make it compelling. So some of the tools that they said, one of our physicians said, hey, Marianne, I need a tool. I need a badge backer. And when I say badge backer, we use them a lot in hospitals. You can see the one on the screen. So this fits on our employee ID badge, and it helps facilitate the screening. And I'll show you the screening in just a second. But it's very specific in that it's also literacy compliant, in that blue is usually a happy color and red is usually an angry color. And so in our screening tool, once we got it put into our electronic health record, we asked the questions, and there's 4 questions in a validated tool. How often does your partner insult or talk down to you on a scale of 1 to 5? So right there, you've normalized it. Not does he, not are you safe at home, or do you get hit? That would make me feel uncomfortable, because that means I am like the zebra. I'm not a normal person. So how often does that happen? 1 is never, and 5 is frequently. How often does your partner threaten you with harm? How often does your partner scream at you on a scale of 1 to 5? And those are the things that are on there. And how often does your partner physically harm you? And then on the back of that card, we put the resources so that the nurse can just take a look at that, be able to instantly connect, know what the resources are, know how to share them. But it also is in the electronic health record as well. Now that badge backer, this is a funny slide, but that badge backer stopped this from happening, because when we watched people who were screening, they're looking at their computer, asking the question, and not looking at that patient. Just as important as developing the relationships with your community resources is that trauma-informed care and developing the trust that you have with your patient. And if you're not looking at your patient, you don't see what's happening with their face. You don't see their body language. They may want to tell you something, or maybe they don't, but you have to be able to look at them. And that badge backer facilitated that. So this is what it looks like in our electronic health record. And we actually even put, and this was very helpful for those of you looking at organizational change, putting a script in, because when people first start a new tool, especially if something as uncomfortable as asking these very difficult questions, we put a little script in for the staff. When you're asking the screening questions, make sure the patient's alone. You don't want them around anybody else. Ask the patient to, let the patient know that we ask these questions to every single person that comes in. And so one of the things from the feedback that we got from our focus groups was that the nurse's HIT stands for hit, insult, threaten, and scream. And the physician that developed this validated screening tool put them in that order because it spelled the word hits. And so we learned that the nurses didn't like asking the hit question first. They felt like it was too personal, too vulnerable. And so we called the author of the screening tool, because it was a validated tool, and we wanted to replace that old one. And we said, can we mix them up a little bit and ask the same questions, but reverse some of the roles? And Dr. Sharon said, of course you can. It's still a validated tool. And so when we did that, there went our compliance up again. So the workflow was important, giving the nurses some say in how they screen, as long as they're using the validated tool. And then also putting little hints in how to ask these hard questions that can trigger a lot of people. So because of the strangulation commonality of half of all people that have ever in intimate partner violence or strangle, we threw in one strangulation question. And when we asked, this question, and if they say yes, then we ask them a couple of the symptoms, because we want to know. And so that helps our physicians to make the decision as to what is the next medical step to do. But we also told the patients, we also tell the patients, did you know I'm really concerned about your safety at home? because experiencing strangulation puts you at a risk 800 times more likely to become the victim of a homicide later on in life. This is a brand new tool that has been validated only in the emergency department. We partnered, it's called the RAF tool. We partnered with Mount Sinai in New York, multiple other trauma centers across the United States, and actually have 4 questions that again normalize violence and abnormal behavior. And if there is a yes answer to these questions, then we know that there could be some human trafficking happening, and then to offer resources. But normalizing that violence is really important. This tool has not been validated in clinics or urgent cares. And it's brand new. It just came out this past summer. We finally, a couple of years of research, got it done. So that's what we're using for our screening tool for human trafficking as well. We are required as an organization to screen for intimate partner. So again, that also increased compliance. We actually have developed, based on our screening tool, our policy, and in our policy guidelines, which most large organizations or any organization, healthcare especially, has, we included that particular screening tool that I just showed you, the HITS tool, so that there are areas that are not entry points in our hospital that they do not screen on a regular basis. Right now, we're screening at entry points. Our community clinics, our urgent cares, labor and delivery, OB triage, excuse me, I had to think for a second, and our emergency department. We're not screening on the floors routinely, but what if somebody wanted to screen on the floor routinely? So they know that they can use that policy. So I told you we screened 12% of all of our patients when we first started this journey. Last year, we screened 152,875 people. So that was about 70% in our emergency department, which is unbelievably high from 12%. And I will tell you, as an old ER nurse, getting ER nurses to do screenings can be really challenging, but we gain that buy-in and we gain that trust with them. Of those 152,000, we found 364 that were willing to open up, to be vulnerable and say, yep, this is happening to me. And of those, 169 were referred to community resources. Before we started this, we had zero referrals to community resources. We're now getting stories back, and we're getting outcomes back from our patients because they are still our patients. Some of them come in through the ER, but they are our patients in our community clinics as well. And they're telling us how they are surviving, how they are being successful in raising their children, and not with the abuser in many cases. Because of our practice, we've been cited in the American College of Surgeons Committee on Trauma Best Practice Guidelines for the recognition of intimate partner violence and human trafficking. This document goes out to every trauma center across the country. And I'm going to show one scene. I've got a few minutes. Yes, I'm going to show this really quickly of something that is a screening that we practice with. Yep, I'm going to show you. I'm just going to stop talking and show it to you. Hang on. An example of talking to patients. Oh, okay. Really? Here we go. Make it big. And here we go.
Hi, I'm Dr. Rayford. What brings you in today? I was in the garden and I heard you. Okay, let me take a look at that shoulder. Okay. I need you to, I know it hurts, but I need to examine you if I'm going to be able to help you. Okay, it'll be over soon. You said you hit your head? Here?
Okay, so wait, sorry, hang on. Let me get out of there. So that is an example of not trauma-informed care. That's an example of coming in, and this is what healthcare folks do a lot, is that we go in, we want to fix something. So, you know, she said she hurt her shoulder. She didn't ask any questions. She didn't sit down and talk with her. She just went to what she knew to do to fix the problem. So here, and I'm not going to play the whole thing, but I'm going to play a little bit so you can see a little bit of the difference. Do over.
Hi, I'm Dr. Rayford. I understand you hurt your shoulder. Can you tell me what happened?
Well, I had bought some tomato plants to try to save some money on food and planted them with my husband. I guess I should have saved the money. He felt I was saving him and making enough money for me. I wasn't. I was just, well, I tripped over the rake and fell really hard on my shoulder. It just kept hurting worse, and then my head started hurting, and then I threw up. I have to put my kids up a few hours, and I need to make sure I'm okay.
I am so sorry this has happened to you. You don't deserve to be hurt. Can I examine your shoulder and look for other injuries? I'll walk you through what I'm going to do as I do it. Is that okay? I need to pick your hair back so I can look.
So you can, hang on. I'm trying to be techie as hard as I can. You can see a big difference in the way that she approached this patient, right? She acknowledged what happened. She told her, I'm so sorry, you did not deserve this. And when you give a safe space for someone to talk and someone to be able to be vulnerable with you, you create this space that they may not want to accept resources at that time, but you are planting a seed. And so one of the things that we discovered here, and you will, if you choose to make some changes in your organization, you will have people calling you saying they didn't leave, they didn't go to shelter. Well, we know that not everyone needs to go to shelter at that time. In fact, that's a very dangerous thing for some people at that time to leave. We know that's the most dangerous time. So we want to plant a seed. And so what we went back and re-educated our staff because the compliance went down because people weren't making, you know, they weren't doing what the nurse wanted. The nurse couldn't fix it. So we explained that whole process of change. Again, went over the oxytocin and the dopamine and why it takes a little bit to change those pathways, whether it's through trafficking, whether it's because of trafficking or because of intimate partner or combination. What you're doing is you are planting a seed so that every time that person comes back, that you ask those questions, and after a while, they will begin to trust you. We've also discovered a key phrase that seems to really help a lot, especially in our potentially trafficked population. We ask them, would you like to speak with someone who has had a similar experience as you? So number one, we've normalized it. We've normalized whatever their experience is. And if they say yes, that's when we call Unbound and they send in an advocate, or if it's intimate partner, that's when we call our resources for intimate partner. And they can talk to them on the phone, further screen them on the phone. But when you have peer support, when you have someone who is, you and I know that if, you're hang out with people that do similar things as you do, right? And you're more comfortable and it's easier. You don't have to hear the whole story yourself. Leave it to those community partners that you have developed that relationship with. So this is what we use, our community resources. And since we have started this, another organizational change that we have made, because we begin to identify so many people, is that we worked with one of our community partners, and they actually provide two victims advocate, or a victims advocate 24/7. So there's two on 24/7 days a week that will not only see patients in the emergency department, but when I go around on trauma patients in the hospital on the regular floors, if I have somebody that is a victim of crime or any type of injury like that, I can call the victim's advocate. They come up, they get them all connected, and they do their job. I don't have time. I can't fix it all. I need my village. And we also have two specific forensic nurses that will do the forensic interview, the photos, so that legally the correct thing is in the chart. So if these folks go to court at any point in time, the people that are testifying on their behalf or for them have some really good information. So in healthcare, what we've instructed our team to do, and this is something that we're continually working on, is to not say alleged assault. Patient comes in from alleged assault. We don't use that word. That is super not helpful, because we don't say patients come in from alleged diabetes or alleged chest pain because they're having a heart attack. I can't feel their pain. So does that mean it's alleged? No. So what we've told our staff is that everything that person says, you put that in quotations. Patient states, quote, and that way you don't have to make a determination, guilty, not guilty, true, not true, but you are giving that person, that victim, that survivor, the power to do and to say and to be and in that safe space. So it's really important. One of the things also is we've taught our staff 17 and under, they don't get a choice. We have to call 911. We call our local police. We call CPS. They don't get a choice because they're still not a consenting adult. 17 and under is not a consenting adult. So a couple of summary pieces. I'm going to skip through that. So when we first started and thinking about the 12% that we screened and the ones that we didn't, and the no referrals, it was very heavy on me, and it was very heavy on our team. And I came across this quote from Maya Angelou that you do the best you can until you know better. And then when you know better, you do better. That provided not only solace for our team, but it also provided a charge that we learned more. We learned more all about intimate partner, all about human trafficking, the chemicals, the social determinants, what causes people to behave, our own implicit bias. And so that gave us a charge to do better. So I'm not going to do that. That's my contact information. If you want to take that down for any questions, we are happy to share everything we're doing, because it is about improving those people, improving their life and improving their ability to survive and thrive. And so I'm going to stop talking and take a drink of water, and you guys can, Lacey, navigate us through.
Yes. Well, thank you so much for that, Marianne. I do want to open it up, excuse me, for questions. One question I had while others are thinking of theirs is, what advice would you have? I mean, we know in Fort Worth, we have a lot of partners. We have a lot of resources. We have a shelter. We know that a lot of our callers that are participants today are probably in rural communities that they may not have a shelter in their county. It may be, over, and knowing that shelter isn't always the answer for everyone, but just an example. So if I'm going to try as a victim advocate to establish a relationship with my community clinic and maybe see if they can start doing some of this screening stuff, like, what are your words of advice of how to, because we know healthcare can historically be kind of a closed system to access and build those relationships with. So what are some words of advice on how to start that process?
So when you start that process, first of all, when we started it, we had to have our administration, all the people in the carpeted offices approval, right? Because this was a giant change. And we had to educate them just like we educated our staff on prevalence, importance, all the different things that we went through today. But I get calls from Wise County, from outside counties. Marianne, I've got this person here. I don't know what to do. So when you, as if you are in a rural county or a rural organization, I would encourage you to reach out to larger counties that do have the resources. Also, yes, larger counties that do have the resources, to find out if they if they can partner with you, if they can come out and teach you. As a large healthcare organization, we go out to some of our rural facilities, our rural EMS, our rural hospitals, and we educate the things that we know and say, call us up. We will be the one. So rural people can call the larger, and all trauma centers, especially level 1s and 2s, are supposed to be the cogs in communities for not only their county, but their surrounding counties. So that is a tremendous resource that many people don't know because we operate in these silos. So like One Safe Place or Safe Haven or Women's Center, they service people from outside the counties. They do not turn them away. And so, yes, it can be more difficult because you have to connect that person to someplace that's not close to home, but getting them those resources is key in success and developing that relationship, those relationships. I've had many meetings with rural community leaders and members and saying, here's what we do. How can I help you implement it with your workflow? What does your workflow look like? And here's our resources that we are happy to share with.
Yes, and I appreciate that. And when Mary Ann says that she really will help you, she will. I have connected many people with her. And so don't hesitate to email or reach out if this is something that you're interested in doing in your community with your local healthcare providers, whether that's a community clinic or emergency department. But so I don't see any questions coming through. So thank you so much. We really appreciate it. Oh, someone just said, in reference to the JPS victim advocates, what exactly are they discussing with the victims? Safety planning, resources, immediate shelter, etc.
Yes, etc. And also these are social work folks. They have that's their profession and background is social work. And so they've been trained in trauma-informed language and care. And they go, and the safety planning is really important. In that safety planning, again, trauma-informed, it's not saying you need to do this, you need to do that. It's asking that person, tell me the top 5 priorities that you have right now. And so they address and create with that patient a safety plan that, because the patient or the victim or the survivor has identified what's important to them, they address those. So again, when you identify something that's important to someone, they're much more likely to buy in, whether it's nursing staff or even the survivor.
Great, thank you. There is a comment also that an advocate from Denton County Friends of the Family here, and that's in Texas, service clients from all counties in the Dallas-Fort Worth area and healthcare providers are welcome to call their crisis line with questions about talking to victims, questions to ask, resources, etc. So thank you, Grace, for sharing that. We did have one question in the Q&A. How did you get the physicians to quit writing alleged on paperwork? We do not work for the hospitals, but we do exams in hospitals and they write it often.
Yes. So this, speaking the truth, right? We had a particular victim that was a teenager that was assaulted by her boyfriend and allegedly assaulted, as the physician wrote. And it had a very poor outcome later with additional assaults. And as hard as it was, and as difficult as it was, I went back to the physician with an trauma informed with the physician as well, and let him know that that the outcome with this particular patient was deadly. She ended up being murdered, but he wrote alleged in there. And we talked a lot about the justice system and how you can put the quotes in to facilitate the language that the patient uses. And many times, as hard as it is, and it is so time consuming, is going back and re-educating and re-educating. And anytime you can re-educate and share a story that goes along with it, whether it had a poor outcome or a good outcome, if you can connect a human to human, it makes our brains think better versus here's the check the box, here's that. But connecting that human consequence, good or bad, helps with the behavior change in the medical profession.
Great advice there. Any other questions? Okay, well, we are going, thank you for allowing us to, thank you for being here today with us. And then also thank you for allowing us to share your slides. We had a couple folks ask, and we will be sending those out along with an evaluation, which I know Mary Ann is, and wants your feedback. We want your feedback, so please take a minute. And that is how you will get your certificate. So did want to share really quickly, we are, the Conference on Crimes Against Women, which ICCR is a program of, we've opened registration for our 2023 conference. So if you would like to scan that QR code right there and join us in Dallas on May 22nd through the 25th, we would love to have you. And if you have any questions about that, please feel free to reach out to us. And make sure that you are on our newsletter, which you can join on the instituteccr.org, so that you can make sure and not miss any information about upcoming trainings and conference goodies. So hopefully, Marianne, hopefully you'll join us at conference.
Love it. It's an awesome conference. It's an awesome conference.
Thank you. All right. Well, thanks so much. I'll see you soon. Bye.